Morning, everyone, and welcome to today's webinar brought to you by the Centre for Excellence in Rural Sexual Health. I want to begin by acknowledging the traditional owners of the land on which we are on, wherever we're zooming from in Victoria and Australia. We are on Aboriginal land, and I want to pay my respects to elders past, present and emerging, and also extend that respect to any Aboriginal and Torres Strait Islander colleagues that are here with us. Our topic today is Mpox in focus, exploring current and future risks, best practices and effective contact tracing. We've got Kate Van Berkel with us. Kate Van Berkel is a medical doctor and public health medicine advanced trainee at the Loddon Mallee Public Health Unit. Kate views sexual and reproductive health and rights as integral to overall health and well-being. Before I welcome you, Kate, just letting everyone know that this session is being recorded and it is in a meeting mode. So if you do not want to be recorded, just turn your camera off. Kate will do questions at the end of her presentation. So if you want to pop them in the chat during it, you're most welcome to, and then we'll have time at the end to address those. I'm going to hand over to you. Thank you, Kate.
Thanks so much, Ash. Thanks for the introduction. And thank you everybody for joining us today. Yes, I'm going to be chatting with you about Mpox. It's been an interesting journey for Mpox over the last couple of years, and I'm excited to talk that through with you all. I will start by reiterating Ash's acknowledgement of country. I live and work on Dja country up in Bendigo, and I'd like to pay my respects to the Djara people and acknowledge elders past, present and emerging. Djara have been dealing with country for thousands of years, and I do consider myself to be very privileged to continue to learn from First Nations people in that respect. The sovereignty of this land was never ceded, it always was, and it always will be Aboriginal land. It's also worth acknowledging that it is NIDOC week this week, which is very exciting. The theme this year is the next generation strength, vision and legacy. So always really exciting to get along to any of the NIDOC week celebrations that you can in your area and really celebrate this wonderful, resilient and enduring cultural legacy that we have for Aboriginal and Torres Strait Islander people in Victoria, but across the country. Some brief disclaimers as we get into things today. The data used in this presentation are from publicly available sources. That includes the World Health Organization and the Victorian Notifiable Disease Surveillance Dashboard. Just a few content notes. There will be some discussion of sexual activities and there are diagrams and representations, but no photos of human illnesses, just in case that is important for anybody in advance. And very briefly with regard to context, as I mentioned, Mpox has been an evolving conversation in Victoria and some time has passed since Carly and I made plans for this particular session. And once again, the Mpox situation in Victoria has changed. As it stands, there have been no reported cases of Mpox in Victoria for a number of weeks. The public health approach to Mpox nationally has transitioned largely from an elimination strategy to a suppression strategy, and that's largely to acknowledge the kind of risk situation that we find ourselves in at the moment. And that also means that we tend to be kind of looking back on the Clade 2 outbreak of Mpox in Victoria now rather than thinking about it in a prospective fashion. So with all of that in mind, this session I think can be thought of as a bit of a preparedness activity, ensuring that we're all well versed in Mpox so that we can manage importations and incursions of the virus when they do occur, especially if those incursions are of the more virulent clades. But I digress, we're going to get into all of that. So let's continue on. By way of outline of today, as mentioned, we'll get into a quick clinical outline of Mpox, the disease. Then we'll get on to the current risk environment, sort of how we got to the situation that we have been in for the last little while, as well as emerging risks. We'll then talk through some best practices in testing and prevention and some contact tracing concepts and principles. I'll flag early that I'm not going to spend too much time on the nitty-gritty of contact tracing, partly because it's always hard to consider yourself to be well-versed in contact tracing when you're in the same room as the associates of Jane Tomnay. So I won't profess to be an expert in contact tracing, but we will spend a little bit of time going through what I consider to sort of be the fundamentals of good contact tracing. So let's talk about Mpox. Mpox, the disease, is caused by the double-stranded DNA monkeypox virus, abbreviated often as Mpox. Here is our happy little virus. It is a member of the orthopox virus genus of viruses in terms of classification of this particular pathogen, and that does make it a cousin of the smallpox disease, so the variola virus that causes smallpox. Mpox as a virus has two clades, which is a genetic lineage, if you like, of a particular virus, and we describe them as clade 1 and clade 2. Clade 1 used to be known as the Congo Basin clade and can cause a more severe version of Mpox disease. And then clade 2 was known as the West African clade and traditionally caused a milder form of the disease. Each clade does have their own subclades, which are classified as A and B at the moment. So that's where that kind of nomenclature of Mpox clade 1B or clade 2B comes from. It's just classifying which particular genetic branch or child of the Mpox virus, if you like, we're referring to in any context. And then the natural reservoir of this particular virus isn't well described, but we do know that it's found not infrequently in rodents and primates of various kinds, largely across the African continent. In terms of transmission of the virus, Mpox is transmitted through close contact or contact with materials contaminated with the virus. So that might be through broken or open skin, via the oral or the nasal mucosa, via the conjunctiva of the eye, or via very close physical skin-to-skin contact, which is often the form of sexual contact. Some less common routes of transmission include through respiratory droplets or through aerosol generating procedures, through fomites, so the virus living on clothes, sheets, bed linen, things like that. Vertical transmission, so transmission of the virus from mother to child, and bloodborne or sexual fluid related transmissions. That's unusual, but does have the potential to occur. In terms of disease dynamics, I'll show you a little cursory timeline. If we consider day 0 to be the day that somebody develops symptoms of Mpox, and we'll go through what they are in a moment, then we could get a sense of the way that the disease moves and the timeline that it causes that disease on in relation to that day that symptoms developed. So the blue section of the graph that you can see here is the incubation period. So that's the time between when somebody is exposed and when they first develop symptoms. And for Mpox, that's usually about 8 days between exposure and symptom onset, but it can range from anywhere from 3 to 21 days. It's worth noting that the kind of transmission or the transmission route for Mpox might influence that incubation period, in that direct exposure may equal a shorter incubation period versus indirect exposure, causing that slightly longer time for the pathogen to cause disease in somebody. And then the teal bar on this graph represents the infectious period. So that's essentially the time in which somebody can transmit Mpox to somebody else. And that is considered to be from 4 days before the symptoms start until complete resolution of symptoms. So in somebody that has lesions, that would be until the lesions have crusted, scabbed, and fallen off. For people who don't have visible lesions, who have other forms of symptoms, we consider that period to be until the complete resolution of whatever those symptoms might be. And if in doubt, a full 21 days after the symptoms started. Similarly, if you've never had symptoms, so for instance, if you were maybe a contact of somebody with Mpox who was tested as part of screening and was found to have Mpox despite not having any symptoms, we consider you to be infectious for that full 21 days after your first positive test, so the point of diagnosis. Largely speaking, that means most people have an infectious period of about 21 days after symptoms start. All right, let's talk about the clinical presentation. Mpox is usually a self-limiting disease, which means that you don't require any specific treatment. Usually lasts between 2 to 4 weeks and is typified by a rash with pseudopustules. The disease often starts with a prodromal phase, so a cluster of symptoms that come before the really typical rash, and that usually lasts a day to 5 days before the rash comes on. Can include things like headache, lymphadenopathy, so swollen lymph nodes, myalgia, muscle pains, sore throat, back pain, and a fever. And then the rash itself, as mentioned, is typified generally by the presence of pseudopustules. The rash can be localized, so just in one particular location, generalized or confluent, so really spread out and kind of linking together. And it is typically often centrifugal, so not confined, but predominantly on places like the hands and the feet, including the palms and the soles of the hands and feet, or the face. So we see it less commonly on the chest or the trunk. And then in terms of the progression of the rash, it usually starts with macules, so these flat sort of red bumps, which then become papules, raised sort of bumps. Eventually they become vesicles, which means they fill with fluid, and that fluid often has a pustular appearance, so they get that whitehead kind of look. You can see here very small text, apologies, sometimes those pseudopustules get umbilications. In other words, they get these central depressions that look like a belly button, thus the word umbilication. And then eventually they either burst, releasing the pus, or the body sort of reclaims the fluid inside and they become crusted. That usually happens about 2 to 3 weeks after the onset of the rash. And then eventually those crusts themselves fall off and reveal healed skin underneath. Oftentimes it does result in scarring. Interestingly, during the 2022 multi-country outbreak, we were more likely to see people who had quite mild symptoms, people who did not have a prodrome or lymphadenopathy, or if they did in fact have a prodrome, or those symptoms that normally come before lesions or the rash, they actually went the other way around and the rash and the lesions came first before those other kind of clustered of more systemic symptoms. We were also more likely to see people who had involvement of their oral mucosa, as well as people who either had less lesions, lesions that were concentrated to a particular location and not widespread, so often in the genital region, or people who had no visible lesions whatsoever. And in keeping with that, we were more likely to see people who had proctitis, so rectal kind of pain, or urethritis as their presenting symptoms. So they didn't have a rash with lesions, but the suspicion might be that they have lesions in places that can't be seen with the naked eye. Complications are uncommon, especially with clade 2 infections, which, as we'll talk about, is largely what we've seen in Australia so far. They do include things like encephalitis, so inflammation of the brain and the layers surrounding the brain, corneal infection and scarring with resultant vision loss. You can see dehydration, particularly in cases that have had oral lesions, so preventing pain and things preventing your ability to take in fluid via the mouth, or in people who have had significant vomiting and diarrhea that then increases the amount of fluid loss that you have, causing dehydration. You can get bronchopneumonia, secondary cellulitis, so bacterial kind of skin infections in the location of your rash or lesions. And then in rare circumstances, also sepsis, so widespread of the Mpox virus throughout the bloodstream and around the body. Global case fatality rates of Mpox are quite low. The estimates, largely speaking, are 10% for clade 1 and anywhere between less than 1% and 6% for clade 2. That does depend quite significantly on the healthcare context in which the cases occur. So obviously places like Australia with really high quality levels of healthcare, even with clade 1 infections, we're less likely to see a large number of deaths when we have Mpox cases, but you can see there is a slight difference there in terms of the likelihood that a particular clade causes severe disease versus non-severe disease. And then young children, pregnant women, and immunocompromised persons, especially people who are living with advanced HIV, are at the highest risk of having severe disease and developing complications. So that's a bit of an overview of Mpox in general, just so that we've all got a good sense of what we're talking about when we then go through the important aspects, I suppose, of why this disease should be considered important and why we have taken the public health measures that we have when we look at this risk context of this disease occurring. So how did we get to the current risk setting? Essentially, smallpox was eradicated in 1980, so we remember that smallpox is a cousin, if you like, of the monkeypox virus that causes Mpox. And when smallpox was eradicated, smallpox-related vaccination programs largely ceased. So because of that, Mpox emerged as the most public health significant orthopox virus. And historically, we saw cases occurring primarily in Central and Western Africa, with some cases outside of these regions that were largely linked to international travel or to animal transportation. So not a huge amount of spread outside of sort of known endemic areas. Then in 2022, in May of 2022, we saw Mpox transmission reported in multiple regions outside of Africa without prior known cases or local transmission. And that was largely speaking clade 2 that was started occurring in that context. In that same month, Victoria and New South Wales report their first Mpox cases. And then not too long afterwards, on the 12th of July of that year, the World Health Organization declared a public health emergency of international concern. And the Australian CDC followed suit shortly thereafter, declaring Mpox a communicable disease incident of national significance in mid to late July. Throughout then 2023, Australia saw sort of sporadic overseas travel-related and acquired cases. And then from about April of 2024, we started to see the sustained Mpox clade 2 transmission in Australia. And notably on the 14th of August last year, so 2024, the World Health Organization declared another public health emergency of international concern, this one for clade 1b spread from Congo to neighbouring African countries. The first one was about clade 2 getting outside of Africa, and then we start to see towards the end of last year this new and evolving risk of clade 1b. So to show you what that looks like or had looked like globally, this graph is a representation of Mpox cases in total outside of Africa and then within Africa. So it's my left hand, but the colourful side of the graph is cases outside of Africa, and a majority of those, as you can see there in the title, have been clade 2b cases. And then on the African side of the graph, which is that teal colour on my right-hand side, that's a mix of a number of different monkeypox clades. Australia sits within the Western Pacific region, which on that colourful graph there is the light green. So you can see a small-ish number of cases in sort of June of 2024 and then escalating slowly towards the end of 2024 and then reducing again to get us to this situation that we've been at this year in 2025 with a small amount of cases. That region obviously is not limited to just Australia, so that takes into account our cases and a number of other cases sort of around the Pacific and in Southeast Asia. But largely does demonstrate a similar trend to what we've seen in Australia. And we'll look at our epidemiological curve specifically in a moment. You can see the Americas has also followed a similar trend, and that's largely been driven by cases in the United States, Canada and Mexico, but a number in Brazil as well. To demonstrate that in a slightly different way, I've got a geographical representation of total Mpox cases in the last 12 months. So that's May of 2024 through to May of 2025. You can see the vast majority in terms of fewer case numbers are still occurring in the Democratic Republic of Congo, that deep navy country there in Central Africa, with a number of cases spread to the neighbouring countries, but then also a reasonable amount of cases here in Australia, in Brazil, and in the United States, as well as in a couple of other large countries throughout the Americas and in Asia, as well as Europe. So that's the kind of current geographical spread. As we mentioned before, most of those outside of Africa cases have been clade 2, and Africa themselves have seen quite a mix of those two different clades. In terms of the demographics of the Mpox cases that we're seeing outside of Africa, overwhelmingly, this has been a disease that has affected people who have identified as male, and the female cases in that context are a very, very small percentage. You can also see, largely speaking, it is a disease of younger persons, and outside of Africa, very few children have contracted, or at least been reported to have contracted Mpox. That distribution reflects what we've seen in Australia as well, and we will get into a little bit more of the specifics of Victorian cases and the proportions and age demographics for those as well. In terms of our Australian epicurve, you can see here we have that small bump associated largely with imported cases at that sort of midpoint of 2022. And then this bigger curve on the graph here is the sustained local transmission. As I mentioned, this is Australian epidemiology, so it is all states and territories, but largely speaking, this section of the graph has been driven by transmission in New South Wales and Victoria. You can also see nicely demonstrated on this graph, though, that after a very large, compared to 2022 at least, peak through the second half of 2024, our case numbers have fallen quite significantly to a point now where, as mentioned, we've not seen a case in Victoria in a number of weeks. As mentioned, these, I believe this entire graph, because it cuts off a little bit earlier than the recent imported clade 1b case in New South Wales, have been clade 2b versions of the virus. So for Victoria specifically, since the outbreak began in 2022, you can see our local case numbers mirror that curve that we'd just seen in Australia on the previous slide, with 70 cases in that 2022 period, very few imported cases, just 8 in 2023. A large number in 2024, a total of 488, and then through 2025 we've seen that taper off, and we're at least at time of writing at cases of 64 for the 2025 year. As mentioned, consistent with what we've seen internationally in terms of spread, 99% of Victorian cases have identified as men. And this graph in the middle is our age distribution in Victoria. So most people, again, consistent with what we've seen internationally, have been in their 30s, but there is a reasonably wide spread. We have had at least one case documented in a child with relevant sort of household transmission, but largely speaking, similarly, this has been a disease that's affected men in their 30s. There have been sporadic limited cases, less than 5%, occurring outside of metropolitan Melbourne during the Victorian outbreak. And obviously I work at a regional / rural local public health unit, so it's always interesting to consider the way that things differ in the country compared to in Metro Melbourne. And we have seen cases in each of the jurisdictions of the local public health units in Victoria, so a small amount of spread to all parts of the state, but there has been no significant evidence of in-region spread. In other words, cases, largely speaking, have had contact with people in Melbourne rather than the virus getting a foothold, if you like, outside of the city and spreading within communities in the country themselves. There is always, though, that risk of importation to the regions themselves when we have cases inside of Melbourne. Important risk factors of note for our cases in Victoria have included male-to-male sexual contact. and that's between people of any and all sexual orientations. And in particular, if that contact occurred at a sex on premises venue, a sex party, during group sex, or at another form of sex positive gay and bisexual men who have sex with men type event. Thankfully, consistent with global trends, we have largely seen mild symptoms in cases that have occurred in Victoria, and most cases have not needed to access clinical care or treatment after the point of their diagnosis. So just to sort of summarise our current risk, the risk from sustained community transmission in Victoria is now lower than it has been in recent years, but there is still that risk of sporadic imported cases and incursions, particularly from overseas travel. And specific populations should therefore continue to consider prevention measures to protect themselves and the community. So definitely don't feel like because the large curve of the outbreak has largely subsided that we're not going to see any Mpox. We very well may continue to, and it's important that we keep it at the forefront of our mind so that we can limit the spread should it arrive again. Which brings us nicely to a discussion of emerging risk, particularly as we anticipate potentially seeing the change in the clade that's being imported to Australia over the next sort of couple of months to years. So let's look at clade 1b now in particular. Another map demonstration. So you can see this map from the World Health Organization has got in orange, hopefully you can read them, I appreciate they're quite small text on the screen, but the orange countries are countries with sustained community transmission of clade 1b Mpox. So largely speaking, again, that's still concentrated in Central and through to sort of Eastern Africa. Cases linked to travel are highlighted in yellow. So a number of countries have had clade 1b cases that have demonstrably been linked to travel. That has been the case for Australia as well, as we had our first case of clade 1b Mpox in a return traveller to New South Wales in April. We didn't have any onward transmission from that case, and it remains our only case of clade 1b so far. On this World Health Organization diagram, the teal colour indicates a previous clade 1b Mpox case or cases, and so after a couple of weeks, if you've had one and then no sustained transmission, you stop being represented in yellow for a case linked to travel and just start being linked to somewhere where transmission has been reported previously. As you can see, a number of travel-related cases occur sort of across the world, including in South Asia, Europe and the Americas. And it's worth considering the fact that if clade 1b establishes itself in any of these sort of locations that Australians frequently travel to, then the areas that we might need to consider high risk from an Mpox perspective for travel might change, whereas at the moment we largely still think about that travel in Central Africa. To look specifically at Central Africa in a bit more detail, these two graphs show the age and sex distributions of Mpox in Nord and Sud, so North and South Kiva in the Democratic Republic of Congo. Both of these provinces have had a predominance of clade 1b virus driving these graphs. And you can see that the gender demographics and age distribution are very different to the graphs that we'd seen previously for cases outside of Africa, which had been predominantly clade 2b. So, for instance, there's a lot more equality between the sexes in terms of case notification, so a lot more female cases. And this curve, rather than having that sort of peak in the 30 to 40 age range, we actually see peaking at the lower age range, so for children. There's likely a number of reasons for that, not exclusively clade-related pathogen behaviours. In other words, it's not necessarily the fact that it's clade 1b that is demonstrating these particular results. Some of it might be the way that the humans themselves are behaving in this particular region, but the demographic differences are worth considering. Why? We mentioned that clade 1b can cause more serious illness. There is some demonstration from a genetic perspective that a number of virulence-related genes persist in the clade 1b virus that have been deleted or sort of evolutionary bred out, if you like, in the clade 2, clade 2 Mpox viruses. And that this might be driving some of the differences in case fatality rate. But as we mentioned, there are lots of different factors that come into how likely it is that you get very sick or die from Mpox. There's some suggestion that clade 1b may be more transmissible with or without sexual contact, which is obviously important where we've seen with clade 2b a predominance of sexual related transmission in particular cohorts. There are ongoing studies needed to demonstrate vaccine effectiveness. That's true for all of the Mpox clades, but certainly it includes clade 1b. And as we've just seen, internationally, we have seen more spread among people who are at higher risk of severe disease. In other words, if we have more women who are being infected with Mpox, we are more likely to have a proportion of young reproductive women. So therefore people who might be pregnant, who are at more risk of severe disease. And similarly, if we're seeing an increase in cases among children, we know children also are more susceptible for complications and severe disease than the adult population as well. So all of those things together mean that it may be easier for Mpox clade B to establish itself within the Australian community when those incursions do occur, and that they therefore might cause larger, more sustained outbreaks. And that if outbreaks do occur, the people who are infected may suffer more because the virus may be more severe and the people who are being infected are of a different and higher risk demographic than we've seen with clade 2B. So all of those things mean we need to remain vigilant. So with that in mind, let's talk about testing, because this is one of the things that we can do to help identify outbreaks and therefore stop them from spreading. So if you suspect someone has Mpox, what testing do they need? What testing is going to yield the most helpful results? Gold standard is a polymerase chain reaction, so a PCR test, and that's usually done with sterile dry swabs. This particular test looks for the monkeypox virus proteins in the sample. As mentioned, it's usually swabs. You can also send a biopsy or a lesion crust directly to the lab to be PCR'd as well. Where you take that sample from, so the site depends on the symptoms and the exposure history. So if the person has visible lesions, then you can swab the lesion fluid. The tissue itself, which is often the base of the lesion, you can de-roof the lesion if you need to really swab out the base of it, or as mentioned, the crust. In people who present with proctitis, so that anorectal pain, PR bleeding, or a history of receptive anal intercourse, it's a good idea to take an anorectal swab as that Mpox might be present in that location and cause those particular symptoms. And then in people who have a history of receptive oral intercourse or who are experiencing those early prodromal symptoms, you can take a swab of the throat or the nasopharyngeal region and send those for PCR as well. Ideally, if you can, take a swab from multiple sites, particularly if people have a number of those symptoms, so that you can, I guess, increase the chances that you pick something up if it is present, the Mpox virus. And then if need be, other samples can be used, things like serum or whole blood, urine samples for PCR or conjunctival swabs, depending on, again, what kind of exposure or symptoms people are having, but those should be discussed with your friendly neighbourhood microbiologist. You're encouraged to test anyone with compatible symptoms, but in particular, people who have specific risk factors for Mpox. So that includes, as mentioned, gay and bisexual men who have sex with men, people who are travelling to endemic areas or places with active outbreaks. So at the moment, as mentioned, that spread of clade 1b means we're particularly concerned about clade 1 in people who might have travelled to Africa, but that risk is changing as the epidemiology of where the virus is occurring is changing. And then also people who are engaging in travel for sex tourism purposes. It's worth noting that Mpox can resemble other vesicular rashes, so would definitely recommend Mpox testing in presentations that you might otherwise consider to be varicella, so chickenpox and shingles, herpes simplex virus, and we have seen cases in Victoria where people have diagnosed a case with HSV that ended up being Mpox, and then also the great mimic syphilis, particularly if people present with that rash that can be a demonstration of secondary syphilis. Mpox vesicles, particularly if they're in their disseminated or generalized rash form, can have a similar appearance to syphilis as well. And the occasional single lesion in the genital region can mimic things like chancre that present as that first presentation of primary syphilis as well. And then the other important thing to remember with testing is to protect yourself. So always wear appropriate PPE when you're testing. That should include, in a general sense, because you're likely swabbing things with fluid-resistant gown, disposable gloves, eye protection, and that might be goggles or a face shield, and then a fluid-repellent surgical mask. And you can consider upgrading to a P2 or N95 respirator, particularly if people have respiratory symptoms. If there's any suspicion for varicella, that's to protect you from varicella rather than the Mpox aerosols. If you're likely to have prolonged exposure to somebody with suspected Mpox, or if you're engaging in aerosol generating activities. Often that occurs in a hospital setting, but it's worth noting that things like fluffing or airing linen can create aerosols, and helping people who are unwell with Mpox and have respiratory disease in things like the shower can also generate aerosols, so just keep that in mind as well. And then finally, a couple of notes. Mpox is currently an urgent notifiable disease in Victoria. So if you are testing somebody for Mpox, it's a good idea to give your local public health unit a call. So if you're in the Loddon Mallee region, that's me, to discuss the risk and facilitate any relevant public health actions if you do suspect that somebody has Mpox. Lovely. Let's talk about prevention. This is where the money is. So prevention, essentially, there are two main things that we can do to try and minimise the spread of Mpox. And as mentioned, this is where the money is in terms of preventing ongoing spread and being able to keep people healthy and well, which at the end of the day is the entire point of the reason that we do this work. Largely speaking, we can categorise that in two ways: behaviour modification and vaccination. And vaccination refers to both primary vaccination and post-exposure prophylactic vaccination. So in terms of general behavioural prevention, there are a number of things that people might consider doing or that you might discuss with people who are looking to decrease their risk of contracting Mpox. Unsurprisingly, that includes avoiding contact with people who have Mpox. It also includes considering limiting one's sexual partners, and that's particularly during periods of high transmission. So when we had that peak of Mpox cases in late 2024, but also for 3 weeks after returning from countries with active Mpox outbreaks. Again, because we know that infectious period is about 21 days long, so that limits the likelihood that if you did have Mpox and were potentially able to transmit it, that you give it to lots of people if you've reduced the amount of people that you're having that really close, intimate contact with. It's also recommended to acquire the contact details of your sexual partners to facilitate contact tracing if required. One of the real challenges during our recent Mpox outbreak in Victoria was that a lot of contact was in the form of casual engagements, and people didn't necessarily have specific contact details for their intimate partners, which meant that we really could do very little in terms of tracking down who those people were. So regardless of your kind of decisions for behaviour in terms of how many partners you have, having their details should you need them, even if it's just a contact phone number rather than a name and address and things like that, can really help if you did happen to have Mpox. And then maintaining good hand hygiene is a good general preventative measure for many infectious diseases, including Mpox, because we know there is the potential to transmit the virus through various forms. It doesn't just happen from that sexual contact. It can be any form of close skin-to-skin kind of contact. And there are a number of things that we consider, particularly in the wake of seeing those numbers in terms of child transmissions outside of Australia, that we think about in terms of caring for other people. So maintaining good hand hygiene is another effective way to reduce your risk. Using barrier contraception can be helpful, particularly if you're having sex while you're travelling or you're attending a sex on premises venue or other events where you're expected to have intimate contact with a large number of groups. It's worth noting again, because Mpox transmission does occur with close physical contact, skin-to-skin contact, barrier contraception isn't always completely effective, but it can reduce that risk. And then also checking the Australian Government's Smart Traveller website for alerts prior to travel to endemic regions to help give you that overall sense, essentially, of where transmission might be occurring and therefore ways that you might be able to modify your behaviour overseas to reduce your risk. In terms of vaccination, we'll talk about primary preventative vaccination first. I'm just going to pause for a drink so that I don't end up in a coughing fit that then means that I can't talk to you for longer. Beautiful. The primary preventative vaccination, largely speaking in Australia, is Jynneos. It is a third generation smallpox vaccine, and it's available free of charge for eligible people. It comes in a 2-dose schedule, administered subcutaneously, and those 2 doses are given 28 days apart and take approximately 14 days to be fully effective. Eligible cohorts to receive primary preventative vaccination in Victoria include gay and bisexual men who have sex with men, trans and gender diverse people who might be at risk of Mpox, particularly if they do engage in sex with men, sex workers, people who are living with HIV, and then importantly, the contacts of any of those aforementioned categories. So if you are in a relationship with someone who's living with HIV, then you're also eligible for Mpox vaccine, even if you yourself do not have HIV. And then other eligible people include people who work and visit sex on premises venues, people who have occupational exposures to Mpox virus. So obviously, we've listed a number of kind of occupations so far, but this one specifically really references people who work with viruses in the lab, for instance. And then, as mentioned, we know there's a significant risk associated with travel, so it is largely speaking also recommended for travellers who are likely to undertake sexual risk activities in countries with transmission of clade 1 virus. So, for instance, if you're an Australian who has relationships with people back home in the Democratic Republic of Congo, and you're going to go home and visit them and potentially have intimate relations with them, then we'd recommend that you have an Mpox vaccine before you go. And then, as mentioned, we can also use the vaccines, the same vaccine, for post-exposure preventative vaccination. So what are we talking about here? It looks very similar in that it is also free. If you've never been vaccinated before, we give the first one as post-exposure preventative vaccination, and then we do a follow-up dose in that 28-day period as well, so that you've had the full course. It's still given subcut. And ideally, we like to give the vaccine within 4 days of your exposure to somebody who's had Mpox. We can give it up to 14 days later. Within that 4 days, it's really good at preventing you from developing Mpox. And within the 14 days, but past that 4 days, it's usually better at attenuating disease. So in other words, making it more likely that you'll be largely well with Mpox rather than stopping you from developing the disease at all. And the eligible cohorts for post-exposure preventative vaccination, largely speaking, are determined by local public health units and assessed during that contact tracing period. The eligibility is based on the type and extent of exposure that a person's had to someone with Mpox. And as mentioned, largely speaking, it's recommended to contacts who are not fully immune. So that's prevention. All right, let's talk about contact tracing. As I mentioned, I won't spend too long here because it is hard to call myself an expert talking to people who work with Jane, but I will go over the foundations, if you like, that I consider to be foundations of good contact tracing. So we'll talk about the purpose, broadly speaking, some specific concepts, including upstream and downstream contacts, and classifying contacts from an Mpox perspective as high, medium, and low risk, and then some specific principles with regard to contact tracing, and they are, largely speaking, to be non-judgmental, non-judicial, and I will describe the difference between those two things because they're very similar words. And then unfortunately, I couldn't find another non-J way to describe this, but the third principle is minimally intrusive. So what is the point of contact tracing? Largely speaking, it is twofold. It is to find the case who infected our case and cases who may have been infected by our case. We collect the details that we need in order to assess the risk level for these particular contacts so that we can inform people of their risk and protect them from developing disease if possible. And that might include things like recommending post-exposure preventative vaccination. The details that we like to collect include name and demographics, an address, a contact phone number. So essentially these two are largely the way to reach this particular person to inform them of their risk. The type of contact or exposure and when the contact has occurred. We try and fit it into that timeline as mentioned to help deduce what kinds of recommendations we might be able to make in terms of how likely somebody is to have contracted Mpox and what preventative measures might be available to them. And then also things like vaccination and or treatment history, particularly if someone's describing a contact that they know has had Mpox. So concept-wise, upstream contacts. These are people who have had contact with our case before the case became infectious, so this half of that sort of diagram. And largely speaking, we're asking about the 21 days prior to the onset of symptoms in the case. It can be really helpful to round up just to a month and cast the net really wide. Honestly, you can do longer if you want to, because recall, as you know, can be difficult. Sometimes I forget what I had for breakfast a particular morning, let alone who I might have come into various forms of contact with over the course of a month. And why is it 21 days that we're asking about? To remind you of our diagram about disease dynamics, we'd seen this blue section of the graph demonstrated our incubation period, which is usually about 8 days from exposure, but can be anywhere from 3 to 21 days. So essentially we're trying to capture contacts as far back as that exposure may have been. So rather than 8, really extending it up to that 21 days, that would encompass anybody who may have transmitted Mpox to our particular case. As mentioned, this can help establish transmission pathways and identify acquisition for a particular case, but importantly, actually, it helps to identify missed cases and link them into care if needed, including other people who also might have been co-exposed by this particular contact. They might not have realised that they've been unwell or were potentially putting others at risk. So it's definitely not a punitive thing. It's just trying to ascertain who else may need support and particular recommendations to keep themselves and their contacts well. And then the other side of the coin is the downstream contacts. Unsurprisingly, that's this half of the diagram. And largely that's a person who our case has had contact with after they've become infectious. And so we're asking about contacts from 4 days prior to the onset of symptoms until the complete resolution of the illness. So again, to look back at our disease dynamics diagram, now we're looking at that teal section of the graph. So from 4 days before their symptoms started through to about 21 days after they first became unwell, depending on exactly whether they had symptoms, where they were, etc., those kinds of things. And we are looking again to identify people who may have been infected by our case rather than causing illness in our case. But as mentioned, the priority is not to deduce kind of, who this person has been spreading to, and we'll talk through the principles that kind of underpin this stuff in just a moment. But it is largely, we're attempting to help identify possible and future cases and link them into care if needed, so including things like giving them post-exposure prophylactic vaccination if they need it. We'll talk through that a little bit more in principles. And then the other concept is the risk level for Mpox. We do stratify contacts in Mpox into low, medium and high risk categories. And largely speaking, that's so that public health authorities can support and make recommendations to contacts based on their risk category. In other words, there might be things that we recommend to someone who is high risk that we don't recommend to someone who's medium risk. And certainly the degree of follow-up that we do for somebody who is a low risk contact and is unlikely to have contracted Mpox is very different to someone who is very likely to have contracted it. And these risk categories, largely speaking, are determined by the type of contact. For example, have they had intimate, close contact, including sexual contact? Do they live in the same household? Do they have shared facilities, things like bathrooms, kitchens, but also linen? As mentioned, there can be particles of the virus that live on linens and other surfaces. So knowing who shares what and who comes into contact with those things, it can be quite important. And then if it's in a healthcare setting, things like PPE details. So if you come into contact with someone with Mpox, what kind of PPE were you wearing at the time? And then increasingly important, the known or suspected clade also helps us determine the risk level and the kinds of recommendations that we might make. So let's talk about principles. This is the nice part, I think, because this really is what turns your contact tracing from being something kind of scientific and dry to something that is human, is grounded in thinking about other people as people, and showing them the kind of kindness and respect that you would hope to be encountered with should you have a cold call from a public health authority. There are 3 of them, as mentioned: non-judgmental, non-judicial, and then minimally intrusive. All 3 of them are crucial in ensuring that the person that you're speaking to feels comfortable sharing the details of their contacts, their exposures, relationships, activities, all those kinds of things with you as the interviewer. And on top of that being important from a human level, it's also the only way that contact tracing can benefit public health efforts. In other words, if you haven't made someone feel comfortable and they're therefore not sharing the full extent of their details, you can't make an appropriate risk assessment and you will miss things in terms of who's at risk. So let's start with non-judgmental. This one's pretty straightforward in that we listen and we don't judge. I like here to really remind myself of the purpose of contact tracing, and that's to safeguard the health of the person, their contacts, and the public, not to pass moral judgment on somebody's behaviours or the way they live their life. I don't care how many sexual partners, for instance, the person that I'm calling has had in the last month. They could say any number between 1 and 1,000, and I'd say, thanks, no problem. Thank you for sharing that with me. If people do feel judged for their behaviours, as mentioned, they're less likely to disclose the details that are required for good contact tracing. And passing that judgment, as mentioned, not only impacts the human experience, but therefore also the quality of the tracing. So ensuring that people do not feel judged in your risk assessment and your obtaining of that information is really important. Non-judicial, which I know sounds very similar, largely speaking, I think about as I'm not the arbiter of who gave what to whom. In other words, I'm not here to help a particular case or contact find out who gave them Mpox for their own interpersonal purposes. I'm here to protect the health of the public. So I find it's often helpful to frame the discussion around discerning who else might need support or testing, rather than that delineation, if you like, of who gave this person the virus and who might they have given it to. This principle, I think, really helps to foster a sense of responsibility and reinforces that the person that you're talking to is doing the right thing by their contacts in the community when they're forthcoming with details. And it can be really helpful, I think, to group all contacts, so in other words, upstream and downstream contacts that we've just talked about together when you're doing the tracing work, and then place them within those categories or that spot on the timeline later for our own public health purposes, and making those distinctions in terms of what we recommend or the kind of follow-up work later rather than conceptualising it that way with people on the phone. So the way you might ask that question would be, instead of who have you come into contact with in the 21 days before you came unwell, you might just ask, from a month before you started to feel unwell until the last time that you had close contact with another person, or if they say that they haven't been anywhere and done anything since starting to feel unwell, then in that month until you started to feel unwell, who have you been in contact with and what kinds of contact? It usually, I think, helps avoid that sort of witch hunt for their acquisition contact, and minimises the aforementioned possible sense of judgment. And then the last principle is being minimally intrusive, which acknowledges that calling someone to ask them about their life and their behaviour, particularly some of the specific questions that we ask in Mpox, is at baseline intrusive. So really we should only ask what we need to ask. Asking more can make the interviewer and the interviewee feel uncomfortable, and that results in less quality contact tracing. With that in mind, there's two sort of types of contact that I think are worth mentioning here. The first one is sexual contact. And that's to say that all sexual contact is equal in Mpox contact tracing. So you don't actually need to know the specifics of the sexual activity to make a risk assessment, which I think is often a roadblock to people conducting contact tracing in Mpox. Worth noting that that's not necessarily so for clinical purposes. As we mentioned, you might need to know the exact nature of someone's activity to help deduce which sites to swab, for instance. But for contact tracing, we don't need it. And then healthcare settings often require a large amount of detail, including things like what kind of PPE was worn, the nature of the care that was provided, what kinds of procedures, if there were procedures happening, how long people were in contact with the person with Mpox. So I often find we actually need to do a little bit less in terms of asking questions about sexual contact, and probably a little bit more in terms of asking questions about healthcare settings. But again, the crux is ask what you need to ask, not more and not less. That brings us towards the end. Just to summarise key messages from this particular session. Local transmission of Mpox has decreased in Victoria, but the risk of importation and incursions continues. International Clade 1b situation continues to evolve, and it may pose a more significant threat than Clade 2b has in the last few years. Healthcare workers, sexual and reproductive health workers, and the public shouldn't forget about Mpox, even though that local transmission risk has decreased, and should know how to protect themselves and their community because of that emerging risk. And like all things in public health, when cases do occur, showing kindness, respect, and building trust are really critical to a successful public health response, and that includes contact tracing. Thank you. Time for questions.
Thank you so much, Kate. That was really comprehensive. I got a lot out of that. Lots of clappy hands, lots and lots of clappy hands coming through. We have just 2 minutes left if anyone had a quick question that they wanted to ask Kate.
Sorry to leave you with such little time for questions, team. I talked slower than I usually do.
It's fine if there's no questions because we're just going to be right on time anyway. Thanks again, Kate. Obviously, you put your details there. This session has been recorded if you want to refer back to it or encourage one of your colleagues to check it out. I would recommend it. I think that was great, Kate, and I appreciate your time today.
Thanks very much, Ash. Thanks everyone for joining. Yes, please feel free to shoot me an email or ring the public health team on the phone number there should you have any questions about Mpox or any other public health issues.
Great. Thank you so much. Bye.